That's a great point. So, um, we looked at five different cardiometabolic risk factors, which included diabetes, hyperlipidemia, obesity, current smoking, and high-risk alcohol use. And the overall finding was that the burden of this risk factor was generally increasing in patients with hypertension over the last 2 decades. And the specific population we focused on was those who had hypertension along with diabetes and hyperlipidemia. So those with triple conditions. And these patients have like multiple comorbidities, so they may have the highest risk of cardiovascular disease. But the joint control of these three risk factors, so adequately controlled blood pressure, glucose, and lipids, was achieved in only 1 out of 4 of these patients. So the joint control of these three factors was lower than 30% across the entire period, which is very sobering. And the trend hasn't like improved over the last decade. So this was like a very sobering observation. That's a very important point, and we are thinking of it as probably related to our point of view of hypertension and related cardiometabolic risk factors. So in like the early and mid 2000s, there were, of course, efforts to improve the awareness, treatment, and control of hypertension along with other risk factors. But the view at that point was looking at those risk factors individually, not as in an integrated fashion or intertwined manner. So all the efforts or performance metrics focused on hypertension on isolation, that they just assess whether hypertension is diagnosed or not, or controlled or not, and made efforts to improve that. And separately for diabetes and separately for hyperlipidemia. And that kind of worked at least probably until 2010. But I think it has now reached its limit. And as I mentioned earlier, these conditions are occurring more frequently in coexistence these days and becoming more and more intertwined, that lots of patients have simultaneously diagnosed with all of these conditions at the same point of time. So that currently the efforts, I think, should shift toward more integrated and comprehensive management of these conditions at once. And I think that is the point and reason why the previous efforts focusing on individual risk factors, but not in an integrated manner, has reached its limit and failed to further improve the management of these conditions as a whole.
And maybe I can just add, I think the challenges here also are that, one provider starting cholesterol medications, one starting the blood pressure medications, you're an endocrinologist, a nephrologist, a cardiologist, and these patients are being inundated with a ton of medications and not a lot of treatment options. And so I think we're starting to see that this, some of these patients make a choice. Maybe they go with the more convincing physician. But maybe we also need to spend more time on making full kind of medical regimens more palatable to the average patient. There's so much polypharmacy. We make a little comment and we think, newer therapies like renal denervation can really be helpful in these situations where patients do have multiple risk factors, will need multiple different agents, and maybe need different strategies to control each of the risk factors. One may be a complementary of procedural and medication. One might be a longer term injection. But we need to do something because this is rather remarkable and will lead to really persistently poor cardiovascular outcomes for our population, who are really primarily multi-comorbid these days.
Oh yeah, so like as I mentioned, I think the biggest challenge is how these risk factors are managed in practice. So in fact, in most of cases, the control of these risk factors isn't like very challenging in itself, but these days the care is so fragmented that even patients with all of these conditions hypertension, diabetes, and hyperlipidemia, for example, have their hypertension controlled in one physician, and then see another doctor for diabetes, and also see another doctor for lipid, so that they have their risk factors, each risk factor controlled or managed by all different physicians. And like by that, those risk factors cannot be like considered in a context of a broader cardiometabolic like continuum or milieu that those fragmented cares kind of fail to account for the coexistence of other risk factors. And I think that is point of, as Eric mentioned earlier, hinders integrated control of these factors and increasing necessary pill burden, lowering patient adherence, and also relate to structural barriers of higher medical cost and those kind of things, like acting jointly that hinders the adequate control, simultaneous control of those risk factors. That's also a great observation, and we all know that obesity is now an endemic, and the prevalence of obesity in general population exceeded 40%, and in patients with hypertension, it now exceeds 50%. This is like not unexpected finding, and high risk alcohol is also like increasing. So, as I mentioned earlier, hypertension should no longer be considered or managed in isolation, but it should be considered in the context of a broader interconnected cardiometabolic milieu that physicians taking care of those with hypertension should also be aware of the presence of other cardiometabolic conditions, including, of course, diabetes or obesity, as you mentioned. And there are lots of like great therapies that can target both hypertension and obesity. So, GLP agonists are very hot these days, and they not only lower weights, but also they help reduce blood pressure. So we should also find ways to like identify and address barriers to the adoption of these very novel therapies that are like effective simultaneously on not only obesity, but also on blood pressure. And in terms of high risk alcohol use, the reason that we included this risk metric in our analysis was partly due to the fact that we thought that this risk factor is kind of underappreciated in the literature. We all know that like binge drinking is bad, but there have also been a long debate on whether like moderate alcohol helps or not in terms of our health. And I think mostly due to that debate, the alcohol hasn't been like enough appreciated in like contemporary risk models or cardiovascular health metrics. So I think one of the reasons that high risk alcohol isn't getting much attention, not from even from the public, but also by clinicians, is that it is like quite underappreciated in the literature. So I think increasing the awareness of the fact that drinking is bad, not only high risk or binge drinking, but also moderate amount of alcohol consumption is bad, is I think the first thing we need to do to address the increase in this metric as well.
Yeah, those are great points. And it's really interesting to reflect because on the one hand, you think maybe those patterns are driving some of the uncontrolled risk factors here. On the other hand, they're also exacerbating them. Like we know alcohol use and weight is such a driver of uncontrolled hypertension. And it also speaks to the potential power of the GLP-1 agonists. We've seen them not only help with weight loss, and as a surrogate to that, blood pressure control, maybe lipid control, but also some of our unhealthy practices can be blunted a little bit with those agents. So, I think that also helps elevate kind of agents like you said, Hyeok, we've talked about that work across risk factors that can really address several of these. And I think GLP-1 agonists are a great target for this population, and in particular those that have some troublesome behaviors, multiple uncontrolled risk factors.
So I think that's the biggest like point and message our paper delivers. So we have briefly talked about this already, but there are lots of novel therapies that can act across these risk factors. So we have like as we talked, GLP-1 agonists, not only helps reducing weight, but it also reduces blood pressure and of course glucose. So it can target hypertension, diabetes, and obesity simultaneously. And uh, in like that, not only in terms of integrated control, but also it's very important to reduce the pill burden the patients are perceiving that uh, like those neuro like device technologies like renal denervation can help reduce the pill burden, and those reduced pill burden can like reuse to like augment therapies for other risk factors. So the device has kind of role in that aspect, I think, too. And there are also like device therapies that are under investigation that targets not only like renal artery nerves, but also like common hepatic artery that has like proven to like not only reduce blood pressure but also like glucose levels. So in overall, like novel therapies are more and more being proven that they like not only target a single risk factor or pathophysiology, but they act across like broader continuum of cardiometabolic like risk factors or conditions that they can work like simultaneously on multiple conditions and help control this multimorbidity simultaneously.
Yeah, I also think, I mean, this is a really great question because I think that, we've started to redefine cardiovascular risk factors as CKM or, cardiokidney or cardiorenal metabolic disease. And this is it. I mean, Hyeok, as the lead author on this paper, really outlined that this is a spectrum of conditions that patients share. And so it has to be holistically managed. And we've seen kind of some newer clinics pop up that target the CKM population. I think that coordinated care and is going to be key. Right now we have a little bit of fragmentation with endocrine and nephrology and cardiology and internal medicine, but we probably need some more holistic clinics if we're going to really, stop this curve or reverse bend the curve, as we say, and make some progress here. And again, just can't focus on just one risk factor in isolation. You got to think about the full patient, and like Yoki, you just said, the full option of therapies that can work across the profile of comorbidities.
So this kind of repeats our previous like discussions, but the biggest point is in overall not considering hypertension as an isolated risk factor, but considering it as a part of a broader cardiometabolic or cardiokidney metabolic condition or health. And so the first thing we need to do is the ways to increase awareness of physicians that hypertension usually doesn't come alone, but on top of other multiple risk factors. In our study showed that like over 90% of patients with hypertension have at least one additional cardiometabolic risk factor, and nearly two-thirds have more than two or more cardiometabolic risk factors coming along with hypertension. So physicians should be aware of this fact and strategies to like advertise or announce that this fact would like be the fundamentum of the ways to promote joint control of these risk factors. And as Eric mentioned, our like health system and performance metrics should shift from the current model of individual risk factor control and assessing whether each risk factor is well controlled toward more integrated model that takes account of this coexistence of multiple risk factors at once, that there should be more integrated care, multidisciplinary approach, and performance metrics should also focus on not only individual risk factor control, but joint control of these risk factors, which has like large gaps to be closed.